Hey everyone. So today we're going to discuss three types of eating disorders and obesity. So anorexia nervosa literally means lack of appetite induced by nervousness. It was first recorded in early religious literature. Changes in DSM-5 include the dropping of amenorrhea, which is the lack of menstruation. So that's no longer required for diagnosis. So typically, doing things like restricting your weight and diet and exercising too much might stop that activity if you're a female, obviously. But that doesn't always happen, so they've dropped that as a requirement for the diagnosis. There are two types of anorexia that have been identified: a restricting type, where every effort is made to limit the quantity of food consumed, and a binge eating purging type. Binge involves out of control consumption of an amount of food that is far greater than what most people would eat in the same amount of time and under the same circumstances. And to purge is to remove food from the body that has been eaten, typically through self-induced vomiting or the use of laxatives. But that could also mean a true purge isn't going to be obsessive exercising, but that does play a role in these disorders as well. Bulimia nervosa is characterized by uncontrollable binge eating and efforts to prevent resulting weight gain by using inappropriate behaviors such as self-induced vomiting or excessive exercise. The term bulimia was first proposed in 1979. It comes from the Greek word bous, meaning ox, and limos, meaning hunger. An argument has been made that binge eating and purge type of anorexia, which is differentiated from bulimia by individuals being underweight, should be considered another form of bulimia nervosa. In bulimia nervosa, individuals are typically a normal or slightly above a normal weight. People with anorexia and bulimia share a common preoccupation with their shape and weight. During an average binge, someone with bulimia nervosa may consume as many as 4,800 calories. After the binge, in an effort to manage the breakdown or self-control, the person will begin to vomit, fast, as in not eat at all, or exercise excessively, or abuse laxatives. Those with bulimia nervosa are often preoccupied with shame, guilt, self-deprecation, and efforts at concealment for their eating behaviors. Binge eating disorder is a new addition to the DSM-5, previously given provisional status in DSM-4. A person with binge eating disorder, it's similar to binge eating or bulimia, but they don't engage in compensatory behaviors like vomiting. So it's associated with being overweight or obese. So here is a chart that compares the three eating disorders for your reference. You might want to keep this handy for your exam that's coming up next week. I also just, FYI, posted the study guide. So if you have any questions about that, feel free to email me and talk about it. It'll be same format as before, and it'll be open for about a week. So although these disorders are often considered to be modern, they actually date back several centuries. Anorexia nervosa most likely developed or is most likely to develop in 16 to 20-year-olds. For bulimia nervosa, the age group at highest risk is young women, the ages ranging from 21 to 24. Recent estimates suggest that there are 3 females for every male with eating disorder. But that is not to say that eating disorders do not happen in men. Gay and bisexual men have higher rates of eating disorders than heterosexual men. Eating disorders are very prevalent in that community. But that's not to say that it can't happen in heterosexual men. It just happens at higher rates for gay, bisexual men, and women. The most common form of eating disorders is binge eating disorder. Worldwide, and based on most recent data, the lifetime prevalence of binge eating disorder is around 2%. The lifetime prevalence of binge eating disorder is around 3.5% in women and 2% in men. The prevalence of binge eating is higher in obese people, and that range is around 6.5 to 8%. Worldwide, the prevalence of bulimia nervosa is estimated to be about 1%. The estimated lifetime prevalence of bulimia in the US is around 1.5% for women and 0.5% for men. The lifetime prevalence in the US for anorexia nervosa is 0.9% in women and 0.3% in men. The risk of developing anorexia nervosa increased during the 20th century. Despite encouraging news of a decrease in the prevalence of bulimia nervosa during the past few decades, many young people, particularly girls and young women in their adolescence and early adulthood, show some evidence of disturbed eating patterns or have distorted self-perceptions about their bodies. Both anorexia and bulimia nervosa lead to serious medical complications. The mortality rate for people with anorexia nervosa is more than 5 times higher than the mortality rate for young females ages 15 to 34 in the US population. Individuals are thin and have brittle hair and nails and dry skin because of the lack of vitamins and nutrients in their diet. Downy hair, or langugo, is observed in the face, neck, arms, back, and legs. Individuals tend to look jaundiced with yellowish tinge to their skin, especially on the palms of their hand and the bottom of their feet. They have difficulty coping with cold temperature because of a lack of fat to insulate them. Patients often feel tired, weak, dizzy, and faint. Thiamine deficiency due to restricted diet may lead to depression and cognitive changes. People with anorexia can die from heart arrhythmias, and it also leads to dehydration, electrolyte imbalances, kidney damage, and damage to the bowels and gastrointestinal tract due to the laxative abuse. The mortality rate for bulimia nervosa is twice that found in people of comparable age in the general population. Bulimia is associated with electrolyte imbalances and low potassium, which puts the patient at risk for heart abnormalities. Abuse of ipecac syrup, which makes you vomit, causes damage to the heart muscles. Tears to the throat, mouth ulcers, and dental cavities are associated with frequent purging, as are small red dots around the eyes, swollen salivary glands, and puffy or chipmunk cheeks. So in this population, a lot of the side effects and complications are very, very dangerous and can lead to some serious medical complications. So studies of patients with anorexia nervosa indicate that even after a series of treatment failures, it is still possible for women with anorexia nervosa to become well again. Long-term prognosis for bulimia nervosa tends to be quite good with high rates of remission. Substance abuse populations, more frequent binges, and more shape concerns, as well as longer duration of illness, predict worse outcomes over time. Patients with binge eating disorder also have high rates of clinical remission, though even when quote unquote well, many individuals who recover from anorexia and bulimia still harbor residual food issues. They tend to remain excessively concerned about their shape and weight. They restrict their dietary intakes and overeat and purge in response to negative mood states. One 7-year study found that the majority of women in the study experienced diagnostic crossover, which means that once someone has been diagnosed with an eating disorder, he or she will be more likely to later be diagnosed with another eating disorder. There is also crossover with other forms of psychopathology. Approximately 68% of patients with anorexia and 63% of patients with bulimia and almost 50% of people with binge eating disorder are diagnosed with depression. Comorbid personality disorders are frequently diagnosed in people with eating disorders. So personality disorders in anxious avoidance, or cluster C, and we're going to be talking about this in next week's lectures in more detail, more so the personality disorders, not the eating disorders. But yeah, so anxious avoidance are found in anorexia and bulimia. Dramatic, emotional, or erratic, which are cluster B problems, include things like borderline personality disorder, are more typically associated with bulimia. More than a third of patients with eating disorders have engaged in self-harming behaviors. People with binge eating disorders have a high rate of anxiety disorders, up to about 65%, and mood disorders around 46%, and substance abuse disorders, which is around 23% in that population. 2/3 of a sample of patients with anorexia reported that they were rigid and perfectionistic, even as children. So there are several different risk factors for developing an eating disorder. As in most disorders, there's a genetic component. Studies suggest that anorexia nervosa and bulimia nervosa are hereditable. The risk for anorexia for relatives is 11.4 times greater than for the relatives of healthy controls. The risk of bulimia for relatives is 3.7 times higher than the rate for relatives of healthy controls as well. There are other physiological components like brain abnormalities. So our bodies also have what's called a set point, and this is a weight that our individual bodies try to defend. So we need to be a certain weight to be healthy. So if we are below that set point, we will be hungry and we will need to eat more. So if you're food restricting, you're really going to have to fight off that kind of set point, and your body will then start to try to retain food and fat to make sure that we're nourished. Serotonin, a neurotransmitter that we've talked about in things like obsessionality, mood disorders, impulsivity. It also regulates appetite and feeding behaviors, which is why you see in mood disorders dysregulations in diet, either gaining weight or losing weight, having a higher appetite or having a lower appetite, because serotonin activity is associated with major depression as well. And that has a lot to do with how we eat. So studies suggest that those with anorexia show low levels of 5-HIAA, which is a metabolite of serotonin. Those with bulimia have normal levels of the metabolite. However, both show higher levels than control during recovery. So this means that the investigation of serotonin as it pertains to eating disorders is a really important area of research. Sociocultural factors include things like peer and media influences. There are a lot of social pressures towards thinness, and that might be particularly powerful in higher socioeconomic status backgrounds. One researcher, Becker, conducted research in Fiji. Initial research findings demonstrated an absence of eating disorders. Being overweight was associated with being strong, being able to work, and being kind and generous, whereas being skinny was associated with being sickly, incompetent, or having somehow received poor treatment. However, when reassessed in 1998, after television was introduced to that society, researchers found that women were dieting and expressing concern about their body weights. So the media has a lot to do with how we really see our bodies and what we idealize as ideal. But there's been quite a movement towards trying to get away from, especially the ideals of thinness that we had back in the 90s when Kate Moss And models like that were seen as the ideal. Luckily, we're getting back to appreciating normal and appreciating every type of body, and seeing more of that on TV shows and in movies and in that. So hopefully that will influence rates of anorexia and bulimia in the future. So family influences are also very important in eating disorders and eating behaviors. More than 1/3 of patients reported that family dysfunction contributed to the development of their anorexia. Many of the parents of patients with eating disorders have longstanding preoccupations regarding the desirability of thinness, dieting, and good physical appearance. Associated family behaviors for anorexia include things like rigidity, parental overprotectiveness, excessive control, and marital discord. Bulimic family characteristics include things like high parental expectations, other family members dieting, critical comments from other family members about shape, weight, or eating, extent of family members making comments about women's appearance and focus on her diet, role of family conflict, and families that are less cohesive. There are also important individual risk factors. First, obviously, being female is a high risk factor. Perfectionism, or the pursuit of unattainably high standards combined with intolerance of mistakes, is associated with eating disorders. It's suggested that perfectionism helps maintain bulimic pathology through rigid adherence to dieting rather that drives that binge purge cycle. Another risk factor is dieting. So nearly all instances of eating disorders begin with a normal dieting that is routine in our culture. Negative emotionality like depression and negative affect are also predictive of developing an eating disorder. And then lastly, childhood sexual abuse is also associated with eating disorders. However, research here is inconsistent. One study found no link between early sexual abuse and binge eating, whereas another found a weak relationship. So while there seems to be a relationship, the causal pathway may be indirect. Okay, so now we're going to discuss some treatments, and we're going to start with anorexia. Patients are generally pessimistic about the potential for recovery and view their disorder as being chronic, which results in high dropout rate for treatment programs. There have been few controlled studies for treatment, and the most immediate concern is to restore weight, and this might require hospitalization and intravenous feeding. Aggressive treatments can backfire. With hospitalization, that's very aggressive. Once you restore the weight and get that individual back out there, if you don't pair it with some kind of therapy, they might not continue adhering to a healthy diet. Medications can also be incorporated into treatment. Antidepressants are sometimes used in treatment of anorexia. However, there's no evidence that they're especially effective. Treatment with antipsychotic medication called olanzapine may be beneficial. Because family factors play a large role in eating disorders, family therapy is used to treat anorexia nervosa. Family therapy is considered the treatment of choice for adolescents with anorexia. In randomized control trials where patients are treated with family therapy for a year, after 5 years, you see full recovery in about 75 to 90% of patients. Medications can also be used in the treatment of bulimia. The use of antidepressants is common. It seems to decrease the frequency of binges as well as improve the mood and preoccupation with weight and shape. The leading treatment is cognitive behavioral therapy. You're going to see CBT coming up in a lot of these pathologies. Multiple control studies show that CBT is superior to medications and interpersonal psychotherapy. Behavioral components focus on meal planning, nutritional education, and ending binging and purging cycles by teaching the person to eat small amounts more frequently. The cognitive element is aimed at changing the cognitions and behaviors that initiate and perpetuate the binge cycle. Because of the high comorbidity with depression, Antidepressants are sometimes used to treat binge eating disorder. Well, pretend like we were on, wow. Pretend like we've been on this slide for a while. Sorry. Yeah, so we're down at binge eating disorder. So binge eating disorders, antidepressants, appetite suppressants are sometimes used. Also, anticonvulsant medications have been a focus of interest in research for treating binge eating disorder. And then research studies also suggest that things like interpersonal psychotherapy might be particularly suitable treatment approach for binge eating disorder. Okay, so moving on to obesity. Obesity is not an eating disorder. It's more of a medical epidemic. Though it is associated with binge eating disorder, obesity itself is a state of excessive chronic fat storage. Stop it, no. Sorry. So obesity is defined on the basis of a statistic called the body mass index. And this is not the best way to define obesity or healthy weight, but it's kind of all we have right now. So take it with a grain of salt. You can have a BMI that is above or below normal weight and still be very healthy and completely fit and within the normal range. So it's just kind of a suggestion to pay more attention to something if you fall within these different levels. So a BMI that's below 18.5 is considered underweight. A BMI 18.5 to 24.9 is considered normal. Overweight between 25 and 29.9, and then obese is over 30. Morbid obesity is a BMI above 40 and being more than 100 pounds overweight. There's also different rates of obesity in different ethnic populations, which you can see right here. So here we have rates of overweight or obesity, and then here we have obese, which would fall within these BMIs, where overweight or obese would kind of fall between these two. So the role of, the obesity is somewhat higher in men than women, which is likely multiple factors playing into that. But I think also to the influence of media and kind of standards, like social standards play a role in that as well, as likely things like cortisol and testosterone. So the role of genes is often discussed in terms of obesity. Thinness seems to run in families. A genetic mutation associated with binge eating is found in about 5% of obese populations. All of the obese people that have this gene reported problems with binge eating, whereas only 14% of people with obesity who did not have that genetic mutation had a pattern of binge eating. Hormones involved in appetite, and you'll need to know this for the test, maybe and weight regulation may be dysregulated in individuals who are at risk for obesity. So for example, leptin, which is a hormone that reduces our acts to reduce our intake of food. The inability to produce leptin is associated with morbid obesity. People who are overweight tend to have higher levels of leptin in their bloodstream, but are resistant to its effects. The hormone ghrelin, which is produced by the stomach, is a powerful appetite stimulator. In Prader-Willi syndrome, chromosomal abnormalities lead to high levels of ghrelin and extreme obesity. And so individuals with this syndrome often die before the age of 30 because of obesity-related causes. There are many sociocultural family risk factors associated with obesity. For example, eating may become a habitual means of alleviating emotional distress or showing love. Also, overfeeding infants and young children causes them to develop more adipose cells and thus predispose them to weight problems in adulthood. So adipose cells, this is just basically fat cells. And when under stress, people and animals tend to eat foods high in fat or carbohydrates. Carbs make us feel good. And fatty food tastes good. So it also makes us feel good. There are several treatments for obesity. First, making lifestyle modifications like changing diet, increasing exercise, and behavior therapy are effective. Many groups exist. However, only Weight Watchers is the only commercial weight loss program with demonstrated efficacy in randomized controlled trials. Crash diets and extreme treatments are considered outmoded and ineffective approaches. Any diet that the person pursues should be sustainable for the lifetime. So that's why they say lifestyle modifications. It's not going to work if you're not going to keep up with it. And that's why a lot of these fad diets and things like really restricting your diet and not allowing yourself to have nice things like mac and cheese, it's not going to work. So you have to be very strategic in kind of what you want to do there. Some medications are used. So there are several medications that have been approved by the FDA for use in conjunction with a reduced calorie diet, like Orlistat, Lorcaserin, and Contrave. There's one that was recently withdrawn from the market due to safety concerns, and that's Meridia. And that's another thing to keep in mind. And, you know, some of these have been approved by the FDA. However, sometimes we find side effects after they've already been on the market that are not really good for you. So that's why you should always talk to a doctor before taking any medication and make sure that while you're on that medication, you're still maintaining that relationship with the doctor to make sure that your health is going in the right direction. Bariatric surgery is the most effective long-term treatment for people who are morbidly obese. It reduces the amount of food that can be consumed at any one point in time. However, recovery can be very difficult. Weight loss may be substantial, though, averaging between 44 and 88 pounds. And mortality rates for that surgery hover around 1%. So that's it for eating disorders this week. Next week, we're going to talk about personality disorders, which will be a very, very fun and interesting lecture for y'all. I'm going to post the exam probably Sunday or Monday. It's already written, and I'm slowly putting it into Web Canvas. So I'm going to make that live for you guys, but I'll give you more than enough time to complete it. And yeah, let me know if you have any questions, and good luck on the exam.